OK. Bonjour, je m'appelle Frédéric Tessier, je suis un coordonnateur de recherche clinique ici à l'Institut universitaire sur la réadaptation en déficience physique de Montréal, organisé par nous à l'IURDPM, en étroite collaboration avec Dorothy Barthélémy, qui est professeure chercheur en physiothérapie à l'Université de Montréal. Elle est responsable du créneau mobilité ici à l'IURDPM, et puis elle est co-chercheuse principale avec Diana Zidarov aujourd'hui.
Thank you. Thank you very much for that warm welcome and inviting me to speak here in Montreal. So I was going to just start very briefly. I set up a talk about the tetraplegic upper limb, and then earlier today, Dorothy and I started talking, and there are some other innovative things that we're doing at KITE Research Institute. So I've juggled a few things, and I'm going to talk about a few of the newer things that we're doing, not just what I had originally intended to speak about, but all interesting. I work here at the KITE Research Institute in Toronto, Canada, and this is so there are 5 buildings that constitute Toronto Rehab Institute, and within I'm a clinician scientist at the Lyndhurst location, which is our spinal cord injury rehab center. So the outline of my talk today for you is I'm going to talk a tiny bit about the tetraplegic hand and something that's, we often talk about tetraplegia, but we haven't really developed, in the field, if you may, we haven't developed the proper nomenclature for the tetraplegic hand because it is a very unique entity in itself. I'm going to talk a little bit about outcome measures and where they're useful in our space, and then talk about the GRASP, which is a tool that I was the lead inventor on, and how that led me into the natural history of disease and really thinking about restoration and reconstruction. So my area of real knowledge, expertise, and interest is the upper limb. And we'll talk a little bit more about some studies that we're doing at the KITE Research Institute, as well as how we're operating our innovative. This is a really important factor. When I graduated from physiotherapy school, if you had a C5 injury, there was a recipe book on how you treated a C5 injury. You would teach them how to transfer in a medical wheelchair. You would teach them how to mobilize in bed, and you would put them in a wheelchair and send them home and say, live the rest of your life with what you have left, right? So we taught them how to live their life with what was left. But over my career, what we've seen is this increased prevalence of incomplete injuries, and now patients have a lot more spontaneous recovery. And not only do they have that spontaneous recovery, we have an opportunity to impact that spontaneous recovery. So that's really affected how we look at people with spinal cord injury. And along with that has come establishing quite a bit of restorative techniques. So, so now we don't just teach people how to use what they have left, we also teach them how to restore some of that movement or function that they've lost. So when we look at the tetraplegic hand, my education, this is a tenodesis grip. It's a wrist dominant hand function. There's sensory loss in the hand, and there's very little or no digit movement. But what I've seen in my career over the years is actually altered hand function. So this is also somebody with tetraplegia, but they have a fair bit of spasticity or stiffness in their hand. So sometimes these individuals also have difficulty performing tasks or using their hands. So although they don't have a true tenodesis, they do have a tetraplegic hand. And so I think there's a lot of important understanding around, we have a much broader range of dysfunction in the hand that we're dealing with. We're no longer dealing with just a tenodesis grip and someone that needs maybe a universal cuff to perform modified tasks. We now have people with spasticity, maladaptive changes, etc. So how we treat this population changes as well. So that's just to give you the context behind, some of the thinking around the hand, and how it's starting to, it's impacting how we treat patients or how we look at them, and how treatment is evolving. So one of the things we do know from the hand is that it's probably one of the most complex units of the body to assess. It's a very complex process to assess the hand. You have multiple joints, multiple muscles, you have the highest density of nerve endings outside of the mouth. And it is one of the places where the most sensory motor integration does occur. So when it comes to assessing a hand, it's quite complex. You can't just look at one muscle strength and a second muscle strength and test the range of motion. You've kind of got to look at a few more things. And that's why assessment is really important. And the purpose of doing such assessments is to discriminate and establish impairment and functional levels for patients, to capture the change over time, and most importantly, understand the disease through the natural history. So understanding the trajectory of recovery or restoration after an injury is really very important because it helps us establish how we are going to develop treatment protocols. So knowing what's going to happen to the hand post-injury is going to define what we do. And I speak as a physiotherapist when I say this, or a rehab specialist. It tells us what to do with the patient. It tells us when to do it, and it'll also give us some insight on how to do it. So I've got up here, because outcomes is really my area of training. One of the things that I've incorporated in my career was really looking at doing a lot of observational work and using assessments. So right now in the space that I work in, which is primarily spinal cord injury, there are 4 primary outcomes that we use. We use the GRASP, there's 3 versions. We use the Toronto Rehab hand function test. So GRASP was designed to look at impairment and function, so it was really designed to look at patients from zero time after injury to 1 year. Really try and capture the neurological impairment to assess the patient's response to FES training, okay? And then the grasp and release test, which is a very old test, it predates the grasp. It was designed to look at patients' response to tendon transfer. So no peripheral nerve transfer at the time, but it was designed to look at tendon transfer and how tendon transfer should be assessed. And now, and all of these hands, the first 3 measures I've mentioned are hand measures. The last one, the QQ and the QT, the capabilities of upper extremity questionnaire and test developed by Ralph Marino and at TJU or Thomas Jefferson, looks at the whole tetraplegic upper limb. So it looks at reaching, it looks at a person's ability to perform reaching multiple times and repetitions. So I would say that if you're looking at using assessments, we've got some great assessments out there now that can really help us define what our patients are doing all the time. So I developed the GRASP, obviously, so I'll talk a little bit about it, but I'll just touch upon it. So we developed the GRASP back in 2006 as a response to the Novartis trial. So for the first time, they were going to do a cervical spinal cord injury trial, and there wasn't an outcome measure to use. So this was a project that was funded by Dana and Christopher Reeve, and we came up with what's known today as a GRASP assessment. This is what the kit looks like, and this is what it tests. So we developed a sensory motor hand function construct where we look at strength, sensation, and prehension. We have, so we have 3 domains within our construct, and then we identified the tests or the subtests that tested those domains. So in the case of sensation, we look at dorsal and palmar sensation with monofilaments. For strength, we actually do very traditional manual motor testing, but we look at 10 muscles of the arm and hand. And then for prehension, we look at the ability to perform grip patterns, and for performance, prehension performance, we actually have them perform tasks. So you have 5 subtests, and each subtest is administered to each hand separately. So there's no bilateral testing when you do grasp testing. So this measure was developed, and it has a very robust psychometric profile, if you may. I spent probably 12 to 15 years of my career validating the tool. So it was very good in reliability, construct validity, concurrent validity. We went on to do responsive research. So we have MDD established, minimally clinical importance established. Probably one of the most robust tools that is available to you as a clinician or as a scientist. We also went on to establish a second version of the tip because people said it was too long. So we did some rationalisis on our longitudinal data, and we were able to develop version 2, which is a slightly pared down version of 1. We recommend that you use version 2 in drug trials or clinical drug trials, where perhaps the hand is not the only focus of your research or study. And we recommend you use version 1 when you're doing maybe a device trial or a focused study on the upper limb and hand. And the psychometric properties for version 2 are quite high as well. So after the rash analysis, we redid psychometric properties, and they're fairly consistent. However, the GRASP version 2 is a little less sensitive than the initial version, and that's obvious, right? Removing items, it would be a little less sensitive. So we also went on to develop a version myelopathy to be more sensitive to the degenerative population, and that's quite readily used nowadays in the surgical world, but I'm not going to get into the details. So we did quite a bit of work in outcome measure and outcome measure use, and one of my interests has always been to understand the natural history of disease. So to take your time and look at patients longitudinally and assess them periodically. PhD, we did not have recovery profiles like this. So if somebody were to say to me, I'm going to do a study I'm going to do FES study and with patients post-injury, no drugs, just apply some stimulation, and I'm going to need to have a control group now. So I'm going to have a control group and I'm going to have a treatment group and we're going to make a comparison. But over the years of data collection, and this data set is about 130 patients here, we actually have some recovery profiles that tell you what actually happens to these patients post-injury. So this is just an example, but this is published in our MCID paper, and you can see that if you look at strength, you have the opportunity to measure strength in a patient, and you can go anywhere from, so if we're looking at motor incomplete patients, we see that they start around 50 and they can go almost as high as 100. So what that allows us to do is if I'm conducting a study on a patient or conducting individual case studies and so on, I don't need to really do a control group necessarily. We can use some of this historical data and recovery profiles to help us define our sample sizes, etc. So this is one of the nice things that's come out of all of this work is we can see what does happen. And all of these patients, none of them were involved in studies, none of them were involved in drug trials. This is just the natural history, if you may. It was a year of data collection. So we're able to now tell you what income, and we like to with the upper extremity, when I do my work, I like to separate by motor complete and motor incomplete, because I find that it really defines the group nicely. If you put them together, they kind of wash out or they kind of cancel out each other's changes. But if you separate them, you actually have some very tangible profiles to work with. So I find that that's really useful. So we now have, and in our labs and in our clinics in Toronto, we don't typically collect control data in any of our studies. Any of our upper extremity studies, we don't have control groups. We use profiles to help with our. So one of the other things that's really useful with measurement is you can take a look at things like the minimally clinical important difference and see how your patients perceive their improvement and change to be. I want to just preface this with MCID is a metric that has truly been designed for patient-reported outcomes. The GRASP is not a patient-reported outcome. However, the field really did want an MCID for GRASP. So we did establish that. What you can see here, which is very interesting, is that, so the blue line is somebody's strength trajectory. So it's what's happening to them over the course of the year. They're going from about 33 to 56 over the year. The MCID, I believe, is 12. So when that patient goes from 33 to 45, they're telling me, I feel like I'm much better now. I'm much better. The patient can identify with that change and feels that that has an impact on their life. However, they'll continue to improve over time beyond that 12 points, just to make, so their MCID threshold is actually not the best that they get. Their MCID threshold is actually partway through their recovery. And then here we've just demonstrated for you a 40 to show you where the MDD is. So if an individual comes to you, you measure them at baseline and they have 33 out of 100 in their strength on GRASP. By the time they hit 40, you now know that that's true clinical change and there's no error or noise in that change. So the MDD is the minimally detectable in a measure. So this was just to give you an example of how we now start to use these metrics to determine and power studies when we use GRASP. And these are just examples of some of the global rating of change that we used when we do our MCIDs. So I talked a little bit about the GRASP outcome measures, natural history of disease, and how that talks to us or speaks to us about what we can do for our patients. And then I, of course, have a passion about neuro rehab. But one of the things we're transitioning into from neuro rehab is actually neuro restoration. So neuro rehab is where we are minimizing or compensating for functional alterations to bring the person to their optimal level. Whereas The concept of neurorestoration is to try and focus on plasticity of the impaired nervous system and perhaps have an impact on that, which I think is a really big area of interest now for us, particularly with incomplete spinal cord injury. So when I talk about this in our lab and in our clinic, one of the primary factors that we use for restoration is actually non-invasive neuromodulation. So we are very big on FES therapy, peripheral nerve stimulation. We're moving into spinal cord stimulation mainly in a study, but we are very big on these elements of treatment. In Toronto, it's only very recent that we started a peripheral nerve transfer program. We're actually probably the youngest or the most recent program, and we don't do a whole lot of tendon transfer. So the big drive in Toronto has always been around restoration. I think it's really more where the interest of the scientists has been. There's no particular reason, but that's sort of the culture in Toronto. So one of the aspects that we really have looked at and want to implement in our clinics is some of the work done around cortical motor priming and neuromuscular training. So we all kind of know the philosophies around this, where you can improve the cortical or spinal excitability by applying some electrical stimulation to certain parts of the neurological system. And Dr. Field-Folte's perspective is it prepares the system to receive and respond better to functional training, and you can actually stimulate the spinal networks, promote neuroplasticity. So we do peripheral nerve stimulation in Toronto. We also are currently doing a transcutaneous spinal cord stimulation study. In addition to that, so we do have some protocols where we provide peripheral nerve somatosensory stimulation, where we, and most of the time what we're doing is stimulating the median nerve in the hand at a submotor threshold, and having the person do, I call it mass practice, you can call it task-specific training, but an hour of training with their hands with the peripheral nerve stimulation on. And there's a lot of evidence around this through Dr. Field-Folte's lab, and this is actually a treatment we'll offer patients, in our clinic. We are currently doing some transcutaneous spinal cord stimulation and training, and that is being delivered in a study. And this is where we're applying a single channel or 2 channels to the cervical, just over the cervical spinal cord through the skin, and coupling it with an hour to about an hour of mass practice. And I'll talk in more detail about that training program. We also do an awful lot of neuromuscular training with patients with stroke and spinal cord injury. So we do a lot of FES training where we stimulate muscles and couple exercise functional tasks with that. So we do a lot of what's called FEST, functional electrical stimulation therapy. That's sort of the name that's coined. And we often have patients doing anywhere from 40 to 100 sessions of FEST. And in some cases, or many cases, they get some restoration of voluntary activity. In some cases, after 20 sessions, if they don't, we then discontinue FES and move on to something else. So we do quite a bit of this, and we do the stimulation concurrent with the task-specific repetitive movements. So the difference between FES versus NMES is that during FES, you're doing a functional task with the stimulation on, and NMES is just stimulating. We also are doing a fair bit of treatment with the PONS, otherwise known as a hypoglossal stimulator. So this is a stimulator of the tongue, and this was Health Canada approved just prior to COVID. It was Health Canada approved for mild to moderate brain injury. We were able to do a feasibility study with 6, and we had some very interesting results. Shortly thereafter, it was Health Canada approved for stroke, and now we have quite a few stroke patients coming to us, and we're doing some PONS training. The primary indicator for this, though, is the patient needs to have gait and balance deficits. So it's not ideal for somebody that has vestibular problems that cause their balance deficit. It's really the physical or the dynamic issues. So just those are some of the opportunities that we, work with from a restorative perspective. But then we do get into this concept of reconstruction, which is emerging in Toronto. And I think that we're having some nice success with our peripheral nerve transfer patients who I think we're in our very first cohort. We're just reaching about 2 years with some of our patients. But one of the factors that exists is incorporating and finding the right time and place for these patients to have the surgery, because for us, it's very new that the surgery is occurring during their actual rehab intervention. So patients might be at 3 months, 4 months, still in the rehab system, or still in our rehab unit. And how are we managing this? So I feel like this is an interesting dance that we're doing right now. But one of the things I'd like to see is that all patients that are going to have reconstructive surgery maybe have a course of restoration before, maybe after. So these are some of the things that we're going to start to ask. These are some of the questions we're going to be asking in the next couple of years, and start to look at and see, should they be doing some stimulation treatments prior to the reconstructive surgeries? And then after the rehab, follow up with more restoration? Or do they just have surgery and we leave it at that? So I think it's time for us to start to take a closer look at this. And now that we have a broader range of tetraplegic hand, I think we're going to have different options for different patients. So I think one of our big questions because our perspective really is stimulation. So what is the role of stimulation in the post-operative course of peripheral nerve transfer? So that's one of the things we started to take a little bit of a closer look at. And, you know, how do we coordinate all of these factors? And when is the best time for patients to undergo some of these things? So for me, these are some of the questions we're asking. And as the tetraplegic hand changes, how we take care of that hand also changes. And so we're in the midst of some of these shifts. So some of the things we want to think about is, if they're a non-surgical candidate, do they have access to restorative treatments? And after they've had a full opportunity to try anything restorative, can they maybe try some experimental treatments? In our tendon transfer group, we're really wondering, should this only happen after the rehab course, or should we consider, you know, is this something you do, you know, 2 years post, 1 year post, etc.? These are some of the questions that we're starting to ask. And then, of course, we know in the peripheral nerve transfer group that the surgery must occur. It's a time-sensitive surgery, but what should we be doing pre-surgically? Should we be treating them with stimulation, or should we just following them or giving them conventional treatment? And then, of course, when they're done the surgical intervention, how do we, what do we resume for rehab, and what do we put on hold while they have had surgery and recover? So those are some of the aspects that we're going to take a closer look at in the coming years. So in summary, I talked a little bit about the tetraplegic hand. I think we might want to define it a little better in today's world. We have a lot of elements that it is beyond a tenodesis grip now. When I came in, a tetraplegic hand was a tenodesis grip, and I think it's much more than that. I think with outcome measures, we have a great repertoire to work with, and we need to work with them. So we need to really use these measures. They're all very robust. We need to use these to tell us what we're doing and tell us how to do it. I think we need to build more opportunities for restoration for our patients. This is a real big challenge. Some of what we'll learn from our next study in spinal cord stimulation is, how do we overcome the resource issues? So it takes a lot of resource to deliver a restorative treatment. How do we overcome that in our publicly funded healthcare system? And I think we should really start to think about, how are we coupling restoration with reconstruction, and or should we, etc. I think those questions need to be asked. And I think all of these things will lead to sort of a transformation of how we deliver. So I was going to spend a little more time on that, but I'm going to just touch on a few things with you, like some of the things that we're doing at KITE Research Institute. So currently we're conducting an activity-based therapy and transcutaneous spinal cord stimulation study of patients with traumatic, cervical spinal cord injury. Take that back. We have a study design where we're going to dose 20 patients with this program or treatment. Participants will have cervical spinal cord injury, and they'll range from Asia A to D. 2 to 4 of our patients will be a degenerative, so they can be TCM, or they could be a myelopathy, not necessarily a traumatic injury. It is a single-arm study where we assess them at baseline. So we assess them when they come into the study, and we assess them 6 weeks later, between 6 and 3 months later, to ensure that they're stable before we actually start to treat. And then we provide them with 12 sessions of PT without stim and 28 sessions of PT with stim. And our primary endpoint is grasp. You're also using the CRI hand function test. We're INSCI, skim. We're doing an electrophysiology, testing battery. We have 4 patients that have completed the study and 4 patients that are currently in the study, and we're hoping to at least dose about 16 patients before the grant finishes. That's where we are. So our background essentially is that we're going to use activity-based therapy as the couple, or as the therapy delivered, and transcutaneous spinal cord stimulation as our non-invasive neuromodulation technique. And in our vision and from what we've studied, we feel that it improves the spinal network excitability and will enhance the treatment or the patient's ability to respond to the intervention. Our objective is to determine the preliminary impact of combined ABT with spinal cord stim on spinal network excitability, and in 20 patients, we will also be looking at clinical outcomes, but I'm going to just share with you, we have 2 patients with whom we've taken a little closer look at their electrophysiology. So we are presenting this at the National SCI Conference as our late and breaking. So the methods here are essentially the same. We have two males. One is 30 years, one is 74 years, one is 17 years post-injury, one is 5 years post-injury. We offered the ABT program, which constitutes of strengthening, exercise, or partly fitness, postural work, and functional exercises, meaning grip, prehension, and dexterity exercises, or mouse practice. We delivered the spinal cord stimulation at a frequency of 30 to 50 hertz and a pulse width of 500 to 1,000 microseconds. And every patient was started at 5 milliamps, and we progressively increased this to the patient's ability to tolerate. And they were treated 3 times per week for 1 hour. And we did actually see some interesting changes in their excitability. And so the assessment that was done post-treatment was done approximately 2 weeks after the treatment was stopped. And I just put the results here. So we saw that the mean amplitude of the evoked potential improvement curve increased after the ABT and TCS program for biceps, triceps, and the extensor digitorum in both these patients. So we are pretty confident that this program will, we can do some neuromodulation, and we can change the excitability of the spinal circuitry. And we do have quite a bit of clinical data as well, and also a lot of not subjective, but questionnaires and interviews, but we're just in the very early stages of analyzing some of that data. So that's one study that we're conducting, and that's actually why I'm here in Montreal, is to collaborate with Dorothy and her team to try and recreate something similar. I am going to touch just really briefly on our KITE clinics. So I worked 20 years at Toronto Western Hospital with the neurosurgery program, and I worked as a therapist in that program, and that's where I did a lot of my preliminary acute spinal cord injury work. But then I came over to Toronto Rehab in 2017, and Dr. Popovich, who is the director of our research institute, asked me if I would start a sustainable enterprise within the rehab unit. So I am an affiliate scientist. I'm a lead of the KITE clinics. And what is KITE clinics? It's essentially a private clinic. Okay, so it is essentially a private neuro rehab clinic. So we're focused neuro-restorative treatment clinic. We service both the public and private sectors. We provide excellent therapy while integrating a clinical research platform for ongoing study of new discoveries, and our primary source of education, knowledge, translation, and innovation. So essentially, we are a clinic, and all of our therapists are hired by the institution. They're hired by the hospital, but they work in KITE clinics, and we deliver private services for the most part. We also do deliver research services. So I'm just going to show you our structure and how it works. So we built this clinic on a few, the culture of our clinic is around sustainability and access. So one of the things, or one of the gaps that existed, is we invent quite a few things in these research institutes. I mean, all of us do. Ryan does it, Kessler does it, we do it here, we do it in Toronto, but our patients rarely get the opportunity to have access to those discoveries. So one of the purposes of creating the clinic was to provide an entry point or an access point for patients. So if a treatment has become Health Canada approved or approved in some manner that we can deliver it, they, and it's not going to be covered by our OHIP or Ontario system, they can at least access it through us. So that was one of the really important pieces that we wanted to offer our patients. We also find it's an opportunity for us to accelerate sort of the implementation of some of these this new knowledge, and it gives us the opportunity to have a clinical research integration program. So how we actually operate. So within our clinic, we have, right now we have about the equivalent of 8 FTEs of therapists that work for us or work with us. And we have patients that are referred to us, and we get referrals from many places. We get referrals from our inpatients, we get referrals from our outpatients, we get referrals external to our hospital, and word of mouth, surgeons, etc. They refer patients to us. I triage all the referrals with the research team and the clinical team. And if the patient looks like they're eligible for a study, we enroll them into one of the 9 studies that we're currently conducting. If they are not eligible for any of the studies, we offer them clinical services for a fee. So we are what they can access above and beyond or after they have sort of exhausted their healthcare through our funded aid, through OHIP, I'm going to say, for lack of a better term. In addition to KITE clinics, we are also creating a center of excellence in non-invasive neuromodulation, where we'd like to build a community of practice around these technologies. So we have a lot of expertise in FES and use, for example, use of PODs. And so we're trying to bring the community together, particularly clinicians, to say, well, if you're interested in learning about these things, this is where you might be able to get some information. But also patients can connect and find out where therapists reside that offer these treatments. So we're looking to build this center of excellence. This is a little bit part of what we do in KITE. But I'll show you a little closer where does our funding come from. So where does our funding come from? We get a little bit of money from the program and the foundation, but most of our money actually comes from, or most of the funding comes from our patients that pay for the services and the research studies. So if you're a PI and you have a study and you want to deliver 600 hours of a treatment, those PIs now come to us. So they'll come to us, they'll set up a research agreement with us, and they'll say, I'm going to be sending patients to you and they need this many hours of such and such a treatment, and we deliver that. And then they pay us in order to do that. Usually they pay us from their grant. So that allows us to sustain our therapists and keep them. And it also allows us to offer them sort of a service which is always there. So that's the other challenge in research studies. You can only hire your, quarter of a therapist for 3 months. So here you always have access to therapists when we do this. So what you'll see, so what we do is we bring our referrals in, we screen them, we either divert them to clinical services, and we offer physiotherapy, OT, one-on-one, FES, conventional, make splints, etc. We have a chiropractor who treats our post-concussive patients with post-concussive symptoms right now. And we also do a little bit of in-home treatment. We have some group therapies that we offer, and this is offered mainly to people with spinal cord injury, stroke, MS, and Guillain-Barré. We also have started a peripheral nerve program within KITE clinics, and so the therapist resides within KITE clinics, and any patients that are having peripheral nerve transfer see this therapist before and after they're followed for 2 years by that therapist. And if they don't need to be in a program, or they're eligible, we currently have actively 7 studies running out of the clinic, one which is ours or mine, the spinal cord stim, and we're going to dose 5 stroke patients in the same way in the next 1 to 2 years. But they then can be enrolled in any study, so they can access more treatment, more therapy at no cost when they're enrolled in the study. So this is generally how we operate our entity, and if you have some specific questions about how we've created that, I'd be more than happy to answer them. And just to sort of find, so our pillars in our KITE clinic. So what we want to do is we want to be able to offer clinical research activity so that we can accelerate implementation. We want to have a higher impact of rehab services delivery by creating access to innovation. And we also would like, and hopefully if it's really successful and we have very high volumes, we can eventually use some of our service time to deliver services that are at no cost to our patients. And that would be about 25% of our service if we can get approximately 70 to 75% of our services paid for by the patient or insurance companies. So there is an opportunity to also deliver to patients that don't have funding. And then, of course, to build this center of excellence within our clinics where we can foster and share, the sharing tradition and build excellence outside. Because one of the biggest challenges is access. So if you live 2 hours outside of Toronto, you do not have access to any of these things. And so really important for us to start to build capacity outside of our centralized system. And I'm going to stop there.
Yes, maybe I would like to know more about how you plan to collaborate and how both expertise will join in the SIM program.
Sure.
Yeah, I can answer that. Well, as you can see, Dr. Kalsi-Ryan has a lot of expertise on the hand function, and within the SIM program, which is funded by the Lindsay Rehabilitation Hospital, there is one project with the therapists that are here actually that also, most of these therapists actually also work on nerve transfer. Is that correct? Where they do have this need to improve or increase the rehabilitation or maximize the recovery of the person using different methods. One of the methods is the spinal cord stimulation that we just, this morning, that's what we were doing, trying to go troubleshoot. And that's what we're going to be trying to co-construct here also with the clinicians, where this could be available as well here to patients that are inpatients, but also chronic patients. But so definitely that's how this collaboration can be. And also the model that they developed between clinicians and scientists, where they do this collaboration, and it's really thorough. It is for a field over there. I mean, we'll see how we go, but it is sustainable. I think this is something we can look at as well here. So this is the
I was interested in knowing about that part. It's an interesting model and it's sustainable.
Yeah, I think you can maybe talk more
Sure.
about this model.
So one of the hardest things to do, I mean, I've been a physiotherapist for 30 years, and I've worked in the public system for those 30 years. And one of the hardest things to do is tell a patient you have to pay for your treatment. So it's really tough. But you have to find, but after a little while, one of the things for me was as well, I'm telling my patient that they don't have access to it just because they have to pay. That becomes the question. So, I mean, we didn't offer any of these things when I was a new therapist. There's quite a bit out there that we're not able to give to our patients. There's quite a bit. So I think we need to evolve along with the field. So the most important aspect I believe, is to inform your patient. So if your patient has a spinal cord injury, you can say, well, this is what you're going to get with me here in inpatient and outpatient rehab. But be aware there's all these things that are available to you, however, they're not covered in our system. And if you're interested in any of those things, I can certainly help you find where to access those. And this is how it is. Because if you don't inform them, they actually don't know about them. So we found that initially the concern was as well, if you're doing a paid, and we do now, we treat our patients, our clinic patients are treated in the same space as our funded, our inpatients and outpatients. And it does two things. So one is patients will say, well, what is that? Can I try that? And we'll say, yeah, that's part of the private services. Would you like to find out about it? And we inform them about everything. And often, I mean, I have very few patients that say, I don't want to, I can't afford it or what have you. So I find that in our system, there's a lot of things that patients can afford to pay for. It's just if we inform them appropriately as to what they're going to get. So that's an interesting sort of shift that has happened for us in Toronto. As far as the collaboration goes, the whole idea is to give as much as we possibly can with what comes in. So if a scientist comes to me and says, and I do have a scientist right now who says, well, I only have about $35 a session to pay you for the treatment. So we're doing that study and I'm covering the rest of that. Whatever it cost me close to almost $60 an hour to have a therapist deliver a treatment. So we fund that with some of the funds that are coming in. So the whole idea of pooling your money gets you a lot farther gets you a lot farther along than saying private over here, covered over here. But if we put it together a little bit, we actually can do a lot more. We have a lot more resource that way.
And maybe it's going to provide data for also the government at some point if the question is raised about, okay, should we include that in the health system? I think that many times it's the monetary issue that is like the first, and then we have more data. So those kinds of candidates provide some data
Yeah,
for
and-
that reflection. So
And we
that's-
collect data. So I mean, I didn't talk about, it's actually you sign when you become a patient in the clinic, you sign a consent form. And anything that we do, we can study.
Well, I would have one last question, maybe, so the spinal cord stimulation, of course, I'm interested into that, because we're gonna go there. How is, are the therapists putting the electrodes themselves? How is it going to work? Because this is a question we had asked for ourselves, because spinal cord stimulation is not necessarily recognized as it's pretty new. OTs, PTs, how do you make it happen that it works, and can anybody put it, and how do you work with the assistant therapist, I think? How does it work with putting the treatment, because it's quite novel?
Okay. So right now we're doing spinal cord stimulation within a study. So it isn't offered as a treatment. But I did check so in Ontario, I went to the first place I went was the College of Physiotherapists to find out. And so as long as it is said to be a therapy, a physical therapist can administer it. We have a slight caveat with occupational therapy. I think what we do is we just ensure that there's a doctor's referral, and if the doctor referral says OT or PT can deliver the stimulation, then that sort of covers us there. So our occupational therapists and physiotherapists actually apply the stimulation unit, apply the electrodes, set the patient up, and deliver the stimulation, just like any other form. We do have PT working with us, and this is a really important, we have to sort of disseminate is, so yeah, great, wonderful, you did it in Toronto Rehab for 20 patients, that's because you have money and you have resources. How are you going to make sure this happens outside of your world, right? So what we are doing with the PTAs is looking for what are the elements of the program that they can deliver, because that will enable us to have, a higher volume of delivery. It will be virtually impossible for us as a field, rehab specialists, if it's only physios and OTs delivering rehab or every aspect of rehab, we will never have the capacity. We just don't have enough physios and OTs available to these patients. So it's really important for us to find what are the elements that other supporting staff can offer. And so those are some of the things that we are looking at. So we do have, right now we have PTAs, physios and OTs delivering all the therapy.
Okay, well, thank you. Thank you again, Dr. Kalsi-Ryan, for this. Thank you.
Thank you very much.